PDA, like Dr. Mohit informed, the PDA is very common condition in premature neonates, and almost everyone who works with in the neonatal intensive care, cannot, go without, getting into the controversies of diagnosing and, managing the PDA. So I would like, in the next 1 hour or so, I would like to talk about briefly, talk about PDA, and then how we can echocardiographically assess the hemodynamic significance of the PDA. The indices, there are a lot of indices. I'm not sure which one is the common indices you are using, but I would tell the common ones and then the less commonly used indices. And also at the end, I will say what is a practical approach, a simple approach which we do in assessing the hemodynamic significance of the PDA. So the talk mainly divided into introduction and the definition of the hemodynamic significant PDA and echocardiographic assessment, indices with lots of videos, and then practical tips and some few words about clinical correlation. Like I said earlier, diagnosis and management of PDA in preterm neonates is the most widely debated subject in the modern neonatology. And actually it's like a pendulum swings, when I'm early parts of my career, we used to treat everyone with indomethacin. And from that, in a mid part of my career, people, the neonatologists swung to not treating PDA at all. And now we come to a balance where, with a lot of emerging evidence, risk-based treatment for the PDA. So in other words, because the PDA medical treatment is associated with the complications, so it's careful risk assessment of the PDA is very important. Which PDA we should treat and which PDA we can get away without treating, just managing conservatively. So for that, it's very important to understand the physiology of the PDA. In term infants, like you all know, functional closure happens by 50% in 24 hours, and most 90% of the PDA is closed in 48 hours. And because we are doing a lot of echocardiograms, even in neonatal units nowadays, I see even day 3, day 4, even in a term babies coming there for other reasons, we see a small PDA, but that PDA is totally insignificant. It's almost closed or closing. So the functional closure is not complete. That sometimes we can see a very tiny PDAs in those infants. But in preterm infants, if the infants born more than 30 weeks, 90 to 98% of the closed by the first week. But the very preterm infants, extremely preterm infants, less than 29 weeks, 28 weeks and below, they are the ones who are at a higher risk of PDA-related complications. And the spontaneous closure, it is very variable in these neonates. Very rarely, I see even a 26-weeker, 25-weeker, the PDA, even on day 1, sometimes, if you are doing on day 1, day 2, the PDA closed. That's very rare. Most of these babies will have a PDA. But which PDA is hemodynamically significant, that's very important to assess to target the treatment. So with that background, I would like to introduce a concept. You all know hemodynamically significant PDA. What do we mean by hemodynamically significant PDA? We can do a clinical assessment. Everyone know that the PDA present with sometimes with respiratory distress and diastolic hypotension, and in a premature neonate, say 28-weeker, on day 2, who is still RDS is treated but still having increasing workup breathing and CPAP dependent, and with a hyperdynamic precardium, and diastolic blood pressure is low with the bounding pulses. And we can clinically make an assessment of PDA in such infants. But this clinical assessment alone is enough to treat these PDAs. Yes, in those days, we used to treat it, but now, it's echocardiography is widely available. It's always important to get an echocardiogram done. 1, to confirm the diagnosis of PDA. 2, to rule out any duct-dependent congenital heart disease, which is important before closing the PDA. 3rd is just to make sure that the PDA is hemodynamically significant. If it is a very small PDA, already closing PDA, probably we can conservatively manage for spontaneous closure. So it's very important to make a risk assessment. So the definition of the hemodynamic significant PDA, if you look at the old literature, it's very variable. Some people, many of the PDA studies have shown that the PDAs are treated, even presence of loud murmur with cardiomegaly, a loud murmur with hyperdynamic pericardium, that is considered as a hemodynamic significant PDA. But only the recent literature, the studies in the last 10 years or so, actually introduced the echocardiographic assessment of the PDA and echocardiographic significant PDA included in the trials. So it's very important to classify the PDA echocardiographically into hemodynamically significant PDA. So the main assessment tools are echocardiography, and the clinical features, like I said, can lag behind. Sometimes, by the time the clinical symptoms appear PDA, the PDA is already a few days advanced and then at risk of pulmonary hemorrhage and others in very small infants. So echocardiography remains the main tool of assessment to assess the hemodynamic significant PDA. Cardiac catheterization is probably the gold standard, but it's not widely available. It's invasive and many infants technically challenging, and it is not worth it, doing just to assess the hemodynamic, because echocardiography now is widely available and is very, very sensitive in assessing the significance. But what we need to remember is there is a lot of intra and inter-observer variation, and also the baby's hemodynamic changes very rapidly. I do a PDA echocardiogram in the morning. The PDA may be a pulmonary hypertension with a very little shunt. The same patient by the night, when the RDS improves, the shunt become very significant, and then the baby might have a hemodynamically significant PDA. So even within the patient, the dynamics changes a lot, and also when we scan between the operators, there are a lot of intra and inter-observer variation. So it's very important. We need to standardize the measurements, and so that we can take to minimize this variation. How do you assess the hemodynamic significant PDA? There are various indices which is available. Like Dr. Mohit mentioned earlier, more than 22 indices available. But I'm going to talk about the commonly used and easily obtainable for the beginner in the echocardiography, functional echocardiography. Okay. So the hemodynamic indices of PDA can be divided into few categories. How I would categorize, the indices mainly focus to assess the shunt size, and then the indices which is focused to assess the volume overload of the left heart, and indices which predominantly concentrate on pulmonary overflow, the increased pulmonary blood flow, and indices to identify low organ perfusion or systemic hypoperfusion. When there is a PDA which is having a diastolic steal, a ductal steal into the pulmonary artery, then there is a decreased blood flow to the aorta and then the abdominal organs. So we can assess that also by point of care echocardiography. So in that category, if you kind of categorize this into 4 categories, it's easy to understand. And there are some practical tips, but this is mainly for our physiologic-based understanding of the hemodynamic indices. Okay, so this is the recent literature. This is one expert opinion from neonatal hemodynamics, the recent edition of the textbook. This is some of the common indices, and then which is actually classified into mild to moderate to severe hemodynamically significant PDA. What are the indices like? Yeah, this talk will be available in YouTube, so you can actually refer to that. I'm just giving a brief overview of the different values. When we go through the different indices, I will go one by one. Okay, so when you talk about the ductal shunt, how significant is the PDA? What is very important is whether the PDA is hemodynamically significant or not. The single most important factor is the pulmonary versus systemic blood flow, QP versus QS. So if I work in pediatric cardiology, the pediatric cardiologist talks about when we do a cardiac catheterization mainly, that's what we measure, QP versus QS. In a large PDA, sometimes the pulmonary blood flow can be as high as 3 to 4 times the systemic blood flow. When you have a high pulmonary circulation, a high QPQS ratio, what it causes is, it causes a pulmonary overcirculation and pulmonary congestion, which causes CPAP dependence, sometimes even pulmonary hemorrhage and heart failure. So, but there are no practical, if you want a 100% accurate measurement of the QPQS, the only true gold standard is cardiac catheterization, which is not available widely, and it's not worth it to do a cardiac catheterization just to assess that. So what we do is actually indirect measurements using the echocardiography, point of care echocardiography. The shunt volume, how much blood goes into the lungs, it depends upon the various factors, ductal diameter, which is actually it's directly proportional to the 4th power of ductal radius, okay, radius of the duct, which is the half the diameter. And also the pressure gradient between the aorta and the pulmonary artery. And it inversely proportional to the length of the duct. If the duct is very long duct, the shunt tend to be slightly lower. And then if the blood is too thick, also the shunt volume is slightly lower. But most of the time, we don't routinely assess the length of the duct or viscosity of the blood, but what we assess is mostly the indirect measurements of the shunt and the direct measurement of the ductal diameter. Okay, so with that introduction, I will go by one by one with the commonly used PDA indices. Okay, and if you have any questions, you can always at the end you can put it in the chat box or in the Q&A column. So the commonly used PDA indices is actually, which I use routinely, we use in the routine, clinical uses. One is PDA diameter, which is easy to measure and which is most important measurement. Second is the PDA to left pulmonary artery ratio. And then third one is the velocity of the shunt velocity, the peak systolic velocity of the PDA, minimum diastolic velocity of the PDA, and then the ratio between these two, peak systolic and diastolic velocity. The fourth is, it's not really an index, but the subjective assessment of the shunt pattern. Actually, it's not a subjective, actually an objective assessment of the shunt pattern. So this is actually one of the most commonly used index. I use it in clinical use. You might, in your institutions, you may use a slightly different indices, but we can talk about that, later. Okay, so just minimize this. The ductal diameter, how you measure the ductal diameter? We can measure in 2-dimensional view as well as the color Doppler. The color Doppler slightly overestimates the ductal diameter. 2-dimension usually more accurate, but you need a slightly high resolution probe. But in most of the newer echocardiographic equipment has got a relatively high resolution probe. For example, in this picture in the right-hand side, the probe is 12 megahertz probe. With that measurement, we can quite clearly see the PDA, and where we measure the PDA is where the PDA at the pulmonary end. The aorta is here, the pulmonary artery is here, and then this is the PDA just at the end of the pulmonary end. So sometimes if you put a color compare mode and by simultaneously, on the same frame, and then you can measure the color. The color, good advantage of color is it gives a nice outline to measure. But the important thing to note when you are measuring is when you have a lot of aliasing, a lot of a high velocity flow, or if the settings are not optimized, there will be a lot of what we call bleeding. The edges of the color will be a little bit not clear outline. If we use that, the settings are not optimized, you often end up in overestimating the ductal diameter. So I usually use use both actually, color compare mode, but I prefer to use it in the 2D, which is actually more accurate. So that's a measurement of the ductal diameter. And one more thing, the ductal diameter, 500-gram baby, 1 kilo baby, or 2 kilo baby, it may be the same size. Whether the effect of the shunt is the same in the different babies, we might argue. So to overcome that weight difference, some advise indexing that means ductal diameter per kilogram of body weight. We don't use it routinely in our unit, but we can index it and then say the ductal diameter 1.5 per kilogram or 1 per kilogram, like that. Yeah, so that's another way. But one more objective way of quantifying the ductal size is the ratio of the PDA size to the left pulmonary artery. I have some pictures in the next frame. So for example, in this frame, the PDA is, you can see the 3-finger view here. This is the 2-finger, one finger is hidden there. So this is the left pulmonary artery. This is the PDA where that's measured. The PDA was measured at 2.66 millimeter in the color flow as well as in the 2D. And in the same picture, we can measure the left pulmonary artery also. And if you look at just eyeball it, looking at the picture, the PDA is as big as or slightly bigger than the left pulmonary artery, which means the ratio is slightly more than 1, equal to or slightly more than 1. And this is the picture, which is actually a video. I hope you can see the video clearly. So we can see this is the left pulmonary artery, which is actually going away from the probe is here. And then this is the PDA, which is gives a very smooth outline. And the third blue flow is this one is the descending thoracic aorta. We are seeing the part of the descending thoracic aorta. So descending thoracic aorta, PDA, and then the left pulmonary artery in the video. And then in the same still picture, we can able to measure the size. So this is how the PDA size is measured. This is actually a good example of a nice PDA, but sometimes it may be a technically challenging, especially if the baby has got a ventilator, baby had an RDS, the lungs are slightly overinflated. We may not be able to get a very good view like this. The PDA left pulmonary artery ratio, like I mentioned in this, again, the picture, the PDA is 2.2 millimeter, and then the left pulmonary artery is about 2.1 millimeter, and then the ratio is 1.04. Anything less than 1 is a moderately significant PDA. If it is in a large PDA, or more severe hemodynamic significant PDA, the PDA ratio is usually more than 1. One of the caveats in that duct PDA size, this is actually one of the recent published literature. The PDA, they looked at the PDA size during cardiac catheterization. It's all neonatal PDAs because in USA now, even the preterm neonatal PDAs are closed by cardiac catheterization. So the images shows the PDA. There are several types of the PDA. The PDA can be like an aneurysmal or a long or a narrow duct, or there are several types. In the bottom figure, type F, this is the most common PDA in preterm neonates, which I showed it earlier. So sometimes when you do echocardiography in the middle of the picture, you can see different types of patterns. Sometimes in a PDA, like I showed it earlier, you can see a very smooth outline in like a tubular type of PDA. But sometimes the PDO is often tortuous. Sometimes, it can be very like a funnel-like appearance, like a narrow pinched here. So you will get different types of PDA. So sometimes it might be technically challenging to measure the PDA, but the rule of the thumb is measure the PDA at the pulmonary end. So we need to get a nice ductal view with left pulmonary artery, right pulmonary artery, and aorta in the same frame. And then with that, with a high resolution probe, if you're able to get a good view, and then we can freeze that image, and then we can measure the PDA at the insertion of at the pulmonary end. Okay, so that's about the PDA size. Next is how do you assess the ductal shunt? Most of the time, yes, even though there are a lot of indices, our just looking at our eyeballing, looking at from the picture with an experience, we may be able to tell whether how big the PDA is and how much is the shunt. So, for example, in this image, the left-hand side, there is a PDA, which is actually this is the aorta in the middle, and there's which is the main pulmonary valve and main pulmonary artery, which is encircling the aorta, and then we can see the 3 vessel view. There is a right pulmonary artery. The left pulmonary artery comes and goes into the view, and then the PDA, which is on the most right of the frame. Okay. The same view, when we see a color Doppler, here it's a right pulmonary artery, PDA, and the left pulmonary artery. The scales are set at 70 centimeters per second. But if you look at the PDA here, we can see only intermittent shunt. You can see some faint red, which is a left to right shunt. So if I freeze it and then move frame by frame, sorry. If I freeze it and move frame by frame, in some part of the cardiac cycle, there is not even a very little flow. That doesn't mean that there is no flow, but because the Doppler is set, the scales are set slightly higher at 70. So that means the flow velocity is less than 70. That's why you are not seeing any flow. So basically this very faint red color indicates that there is a low velocity shunt. And next picture, and then this one, you can see very clearly there is a slightly a high velocity shunt because there is a flow we can see throughout the cardiac cycle. And on the right hand side, again the same. And there is only difference between these two PDAs are the one on the left hand side. The PDA shunt is slightly larger, the size is slightly larger. Here it is slightly narrower at the pulmonary end, and you can see some turbulence or what we call aliasing starting at the pulmonary end, which means there is some restriction, a slight narrowing at the pulmonary end. So just by eyeballing, we can get a lot of useful information about the PDA, whether there is a low velocity or high velocity shunt, and whether there is any restriction to the shuntal flow. And also you can see the shunt, approximately how significant that shunt is. So next is, so that's how this is another 3 vessel view. You can see aorta in left ventricle is slightly modified view with the pulmonary artery, and then we can see the 3 vessels, right pulmonary artery, left pulmonary artery, and PDA. And in this view, the PDA looks bigger than the left pulmonary artery. So definitely this is a large PDA. So most of the time with just the 2D imaging alone, we may be able to tell, judge the PDA size. And this is the parasternal long axis view, which shows left atrium and aorta. The left atrium is definitely dilated, which is the same patient, which is a dilated left atrium. So that's the assessment of the PDA size, and then the shunt, visual assessment of a shunt flow. The next is a visual assessment of shunt pattern. What do you mean by shunt pattern? So the PDA comes with a different type. When we look at the PDA here, if you have a good 2D view, and then if you see the PDA, we can put the pulse wave Doppler at the pulmonary end or adjust at the slightly beyond the pulmonary end of the PDA, in the middle of the PDA, and then that we can assess the ductal Doppler. So when we assess the Doppler, we can get a different flow patterns. This is a slightly old literature, but this is actually quite what I would say now, quite interesting that, this is actually a visual assessment. It was described as early as 1997, but it's still very good and is widely followed. Personally, I like these shunt patterns because it gives a very good hemodynamic assessment of the PDA by just Dopplering the doing a pulse wave Doppler at the ductal level. So typically the ductal flow pattern is divided into pulmonary hypertensive pattern, growing pattern, pulsatile pattern, and closing pattern. So even within these 4 patterns of the PDA, there is a lot of different subtypes, which I will show some examples. So this is a first pattern, which we'll call a pulmonary hypertensive pattern. The picture I showed it earlier in the image where I said the low velocity flow is the same patient. So if you see the ductal cut, we can see the aorta, pulmonary artery, and we see the left pulmonary artery, and then the PDA here, which is actually, you can see an intermittent red color flow, which means a low velocity flow. And then this blue flow is the distal descending thoracic aorta. So when we put a pulse wave cursor, the pulse wave, these are two lines, which is the pulse wave sample volume. If you put a pulse wave exactly in the middle of the there, and then hit the pulse wave Doppler button in the echocardiography machine, and this is the flow you will get. So what we are seeing, this is the baseline. The yellow line is the baseline. The flow above is the coming towards the probe. Is going below the baseline, is going away from the probe. The probe is here where the P is there. The probe is in the top of the picture. So anything above the baseline in this picture is a left to right shunt, and below the baseline is right to left shunt. So, and there is an ECG on the top simultaneously running, and then this is a QRS complex where the systole starts. So the flow, when there is a ventricular systole, there is a slight RV pumps, and then there is a slight high in the pulmonary pressures, then the shunt reverses. So you can see the right to left shunt. So because the pulmonary pressures exceeds the systemic pressure. So there is a right to left shunt at the beginning of the cardiac cycle. And then that's only about, if you take the whole cardiac cycle, and then and the ratio. So this is 90% is actually left to right shunt, and then there probably about 10% which is a right to left shunt. So this is a bidirectional shunt PDA, but it's predominantly left to right, but it's a very low velocity. If you look at the flow, most of the time the flow is about 40 centimeters per second or less. So, but here the scales are set at 70. That's why you are not seeing any color in the PDA. So it's in such a PDA, it's very important. You need to lower the scales. Here this scan was not done by me. My echocardiographer did the scan. So they do a standardized settings. So that's why it was kept at 70. Okay. So this is a pulmonary hypertensive pattern. So this is the baby with a PDA on day 1, a 25-weeker, 800-gram infant with the RDS still ventilated. So the pulmonary pressures are still high. So, but in this such infant, which is actually at risk of pulmonary hemorrhage, when the pulmonary vascular resistance drops, that shunt increases. So it is still safe to close this PDA, because the right to left shunting is less than 30% of the cardiac cycle. Okay, so this is another shunt. This is a baby with a PDA again. We can see there's a slightly larger shunt of the PDA, and when we pulse Doppler this PDA, you see a flow here. The peak velocity is about 120 meters per second, but if you see, it's still a relatively low velocity, which means the pulmonary pressures are still high. So, but it is not a pulmonary hypertension, but it probably a normal high pulmonary vascular resistance, which we see it in the newborn, preterm newborn. So again, in this study, at the end of diastole, you can see the flow is almost coming to the baseline. So at that time, the pulmonary pressures are almost close to systemic pressures. So this is again pulmonary. It's not pulmonary hypertensive pattern, but the pulmonary, it's slightly less, pulmonary hypertensive than the previous example I have shown. The next PDA, this is actually a growing PDA. What do I mean by PDA? You can see very large PDA. It is bigger than the left pulmonary artery, just by visual assessment on the color Doppler. And when we Doppler the PDA, we can see a continuous, flow left to right shunt in systole as well as in the diastole. And the pulmonary pressure is still relatively high because normally if the pulmonary pressures are very low, you will see a slightly different pattern. So, but this is a continuous low velocity left to right shunt. And this is actually a large significant PDA. So on the left-hand side, you can see a PDA with a continuous left to right shunt. On the right-hand side, again, there is a PDA with an even higher shunt, both in systole and diastole. So we can measure the peak systolic velocity and then the minimum diastolic velocity. So for example, on the right-hand side, we have measured the peak systolic velocity is about 1.54 meters per second. And the trough velocity or the minimum diastolic velocity, 0.6. So we can calculate the ratio, 1.54 divided by 0.62, which is the ratio of 2.4. So the peak systolic and minimum diastolic velocity of more than 2 indicates there is a significant hemodynamic significance. And this is another one, which is a larger shunt than the earlier example. The peak velocity is more than 2.4 meters per second. The trough velocity is less than 0.6, which means the peak to trough ratio is more than 4. And this is very easy to measure. Almost all of us with some training can see the PDA. And then if all we need is a quite steady hands, so just hold the hand steady and keep the PDA in the frame, and then get a pulse wave Doppler at the middle of the PDA, and then we can get this view. And then this is quite useful in assessing the PDA shunt. Okay, so that's a large PDA with a shunt. Okay, there's another one, again, large PDA with the peak and trough velocity. So the duct comes in the different sizes and shapes, as I said earlier. And we talked about ductal shunt, ductal size, and then the shunt pattern, as well as the PDA peak velocity and trough velocity. Okay. So different examples. Okay. So that's a different shunt pattern. So this shunt, if you can see that the peak to trough ratio is much less. The peak is 3.5. This is a small PDA, slightly restrictive at the pulmonary end. You can see the imaging is not very good because this baby is on CPAP and quite inflated in lungs. So you cannot see the edges very clearly. But if you see a Doppler pattern, here because the flow is very high, I used the continuous wave Doppler. Previous Dopplers are pulse wave Doppler because the velocity is slightly lower. But any flow more than 2 meters per second, sometimes it doesn't come very well on the pulse wave Doppler. So we have to switch. If the velocity is very high, then you have to use it a continuous wave Doppler. So on the right-hand side, the Doppler image, it is actually a continuous wave Doppler at the ductal level. The peak velocity is 3.5, and then the trough velocity is 2.2. So 3.5 divided by 2.2 is 1.6. So the ratio is still less than 2. And this is actually a slightly restrictive PDA. The baby was still had a loud murmur, because if you hear this PDA definitely will hear a loud continuous murmur. But the baby was actually stable on CPAP, and the baby is slightly bigger. So in this case, we kind of conservatively manage this PDA, and then the PDA is closed spontaneously. But this is an example of slightly what we call a restrictive PDA, which might be closing. So the closing PDA sometimes, this is not a typical closing PDA. The closing PDA looks even smaller than this, but usually you will have a very high systolic as well as a high diastolic velocity. So if you have a high systolic and high diastolic velocity, and then on the color flow image, the PDA looks small, that is an indication of the closing PDA. Okay, so this is the last PDA flow pattern. Again, the image is not very clear. You can hardly see the PDA on 2D because this baby is a late baby, like nearly 40 weeks ex-premi baby with a pulmonary hypertension and BPD. So this PB has got a very tiny PDA. So this PDA is definitely not hemodynamically significant. On 2D measurement, it's measured only 1.2 or 1.3 millimeter. So it's a tiny PDA, but it's very useful to Doppler even this PDA. So this is a bit challenging to Doppler this PDA, but if you make a continuous wave Doppler, manage to get to one Doppler, you see a slightly low velocity, but continuous term, both in systole as well as in diastole. You are getting 2 meters per second in systole and 1.9, about 1.9 or 1.8 meters per second diastole. So the ratio is very small, which means it is not a hemodynamically significant PDA, but what it indicates is the velocity is low, which means the pulmonary pressures are high. So this is a PDA with pulmonary hypertension, but a small PDA, closing PDA, but with pulmonary hypertension. So it's quite useful to assess the shunt in the PDA, and then the Doppler assessment of the shunt will gives a lot of values. One, it gives a hemodynamic significance. Two, it gives an indirect estimation of the pulmonary pressures. Especially if you know simultaneous aortic pressure from the arterial line, we can almost get a real-time estimation of the pulmonary pressures. Okay. Okay. So sometimes we use the term restrictive versus non-restrictive PDA. What do you mean by restrictive PDA? Restrictive PDA, like I said earlier, the PDA looks smaller, and then the high systolic as well as a high diastolic velocity with a continuous flow. So this is called a restrictive PDA. The non-restrictive PDA is almost like an arterial flow. It's a high systolic flow, but it's a very low diastolic flow, which in other words, it's a more of a pulsatile flow. The PDA is merely acting like a conduit. It's a vessel and with no restriction to the blood flow. So when you have a large hemodynamically significant PDA, it's very common to see a pulsatile pattern. So just by looking at whether it's a pulsatile pattern or a high velocity restrictive pattern, we can assess a significance of the PDA. That's another way we can tell just by visual assessment. Okay. So that's the common indices I use. Some of the other common indices we use is the index of left heart volume overload. The commonest index which is used for left heart volume overload is left atrium to aortic ratio. It's again very easy to measure, and it's used to work quite widely. When you have a large PDA shunt, one of the common echocardiographic feature is a left heart volume overload. So there is too much blood goes to the lungs, and this blood returns to left atrium through the pulmonary veins. So there is an increased pulmonary venous return. So when there is more blood comes to the left atrium is distended. And then the left ventricle, all this blood goes to the left ventricle. So the left ventricle is also distended. So you can do quantify the amount of left heart volume overload, and then you can assess the hemodynamic significance of the PDA based on that. Okay, so this is the apical four-chamber view, which you can see very clearly. There is a nice globular left ventricle, which is actually quite dilated compared to the right ventricle, sorry. And then the left atrium is also quite distended. So this is just a visual assessment you can tell that, okay, there is a left heart volume overload there. And if there is a PFO, sometimes, there will be a lot of PFO shunt also when we put a color. This is the apical four-chamber view. On the right-hand side, we have a parasternal long axis view in the same patient. When we see a parasternal long axis view, again, we can just visually compare the aortic diameter to the left atrium diameter. The left atrium is directly below the aorta where the cursor is. So the left atrium looks bigger. So in this view, we can put a M-mode Doppler. So exactly at the level of aortic root, it has to be perpendicular to the the frame, the transverse plane, and then we can measure the left atrium aortic ratio from here. So this is a subjective assessment of left heart volume overload. So next is in that same view, when we get a M-mode measurement, and this is what we'll get an M-mode. So the line and the top line, there is this one is a aortic root, and this one is a left atrium. So we can measure the left atrium measurement from the leading edge to the leading edge here, and then the aorta is also the measurement. I'm not sure how you measure the aorta and the left atrium. We prefer to measure here at two different points, the left atrium in diastole and the aorta in systole. So we can measure the most of the modern echocardiographic machine. If you input the calculation, it automatically gives a measurement, the ratio. So in this picture, the echocardiography machine automatically gives the ratio of 1.78 to 1. So anything less than 1.5 is no PDA or small PDA. It tend to be the LA aortic ratio less than 1.5. 1.5 to 2 moderately hemodynamically significant PDA. In very large shunts, the LA aortic ratio sometimes can be more than 2 to 1. So this is a very useful measurement, left atrium aortic ratio, and you should learn that to measure in practical use. The another measurement is a left ventricular outflow assessment. This is actually a slightly advanced measurement. I think, I'm not sure we don't use this routinely because our trainees, it takes a little bit time consuming. Some of the advanced users use it, but I'm teaching this for completion's sake. In the apical 4-chamber view, and then when we slightly, rotate the probe clockwise, you will get the apical 5-chamber view. So in the apical 5-chamber view, if you do a pulse wave Doppler at just beyond the aortic valve in the ascending aorta, you get a ascending aortic flow. So you can get a flow like this. You can just measure you can just trace the flow, and then we can measure the velocity time integral using most of the echocardiography machines give the VTI measurements automatically, the area under the curve. When we see the velocity time integral, and then we can measure the aortic root diameter, and then you can calculate the aortic cross-sectional area. The cross-sectional area is the area pi r squared, which is a pi aortic diameter divided by 2 squared. You calculate that, and then velocity time integral times the cross-sectional area times the heart rate divided by weight will give the left ventricular output ml per kilogram per minute. You can input this machine, the pre-calculated values into the echocardiography machine. Most of the machines will give the values automatically, but we can manually calculate that also if your echo machine is not equipped with that. In large hemodynamically significant PDA, the left ventricular output is quite high because of the increased stroke volume and increased heart rate. The normal values are less than 180 to 200, 120 to 200. In a moderately significant PDAs, it can be about 200 to 300. In large PDA with a large shunts, the LVO can be as high as more than 300 ml per kg per minute. The another measurement is a left ventricular end diastolic dimension, again measured in the parasternal long axis view using the M mode. And if we know the height and weight of the baby, we can calculate the Z scores of the left ventricular end diastolic dimension. That also gives an objective assessment of left ventricular volume, left ventricular dilatation. The Z score of less than 2 is normal or mild PDA. In moderate PDA, Z scores can be +2 to +3, and in large PDAs, the LV EDD Z scores will be more than +3. This is some examples of how we measure the parasternal long axis or parasternal short axis at the papillary muscle level. Measure at the mitral. This is at the mitral valve level. Measure the left ventricular end diastolic dimension. So this is the same measurement that you measure for the left ventricular function measurement, fractional shortening measurements. The same measurements, we can calculate the left ventricular end diastolic dimension, and we'll calculate the Z scores for that. Most of the echocardiography machines have this calculation inbuilt within the machine. So as long as we are able to get a decent M mode measurement, and then you can just choose that to points of the ventricular septum, ventricular cavity, and then the posterior wall in diastole as well as in systole. And then all the measurements are actually given, calculated by the machine. Okay. So that first two parts that ends the shunt assessment as well as the left heart volume overload assessment. The next is measurements indices for pulmonary overcirculation. So as I said earlier, getting an accurate pulmonary Doppler is important. And in the PDA, in the 3-vessel view, when delineate the PDA quite well, and then you put the cursor exactly in the middle of that PDA, then you get the pulmonary artery Doppler. So in the normal heart, when there is no PDA, when you see a main pulmonary artery Doppler, you will get a nice smooth outline like this on the left-hand side. This is the baby with no PDA. The pulse wave Doppler in the main pulmonary artery, not in the PDA. It is in the main pulmonary artery, just beyond the pulmonary valve. So you can see a nice smooth outline with flow there. But when there is a large hemodynamically significant PDA, you will see a flow something like that in the right side. The flow won't be a very smooth. You will see a lot of turbulence. And some people call it a chaotic flow in the main pulmonary artery. So there is a lot of flow in the diastolic. This is because the PDA just goes into the pulmonary artery, and then it causes the blood actually hits the pulmonary valve and returns back. So that's why there's a lot of diastolic flow in the main pulmonary artery. So even just visual assessment, when I see a main pulmonary artery Doppler, well, when pulse wave Doppler, when I get a flow like this, I know that, hey, this baby has got a significant PDA. And you can measure the diastolic flow velocity in the main and the left pulmonary artery. So when you get a good pulmonary artery Doppler, pulse wave Doppler in the main pulmonary artery, and this is a systolic flow velocity, which is about 60 centimeters per second. And in diastole, end of diastole, with the ECG, you can measure here is about 20 centimeters per second, 0.2 meters per second. On the left-hand side, on the right-hand side of the screen, there is a left pulmonary artery Doppler again, the same pulse wave Doppler at the left pulmonary artery. You can measure the diastolic flow velocity in the left pulmonary artery. So the diastolic flow, the velocity in the left pulmonary artery, in a hemodynamically significant PDA tend to be more than 0.3 to 0.4 meter per second. So this is a baby with a large PDA with a left pulmonary artery Doppler. You can see the diastolic flow is as high as 0.4 meters per second on the left hand. And the same patient, 12 days later after medical closure, the PDA closed, and then you can see a very nice smooth outline in the left pulmonary artery with no diastolic flow at all. So this is the normal left pulmonary artery flow. But when you have a PDA, there is a lot of diastolic flow in the left pulmonary artery. So that's another index. The diastolic flow of the left pulmonary artery is a useful index to measure. This is again another example of main pulmonary artery Doppler and the left pulmonary artery Doppler in a baby with a PDA. Main pulmonary artery, there's a lot of chaotic flow, lot of diastolic flow in the main pulmonary artery. And in the left pulmonary artery, again, the lot of diastolic flow, 0.3 to 0.4 meters per second. This is another example of a large PDA. The patient which I showed earlier. So you can have a 2-vessel view, large PDA with a large shunt. And then the same patient, when we see a Doppler here in the left pulmonary artery, which is on the right-hand side, the diastolic flow is as high as 0.5 meters per second. The peak systolic velocity is 0.9. The diastolic velocity, maximum diastolic velocity is as high as 0.6. So this is a large hemodynamically significant PDA. One more measurement in left apical four-chamber view is mitral valve EA ratio. This is again a relatively easy to measure. On the apical four-chamber view, you pulse wave Doppler mitral inflow just after the, just beneath the mitral valve. We will see the E and A wave. E wave is actually the passive diastolic filling, and A wave is due to the atrial systole. Newborns often will have a slightly restrictive diastolic function, so they rely mostly on the A wave. In a normal patient, the A wave is almost equal, or A wave is slightly higher than the E wave in the premature newborn. Yeah, so on the right-hand screen, you can see the E wave and then the A wave. The A wave is slightly higher than the E wave. In other words, the EA ratio is slightly more than 1 to 1, more than 1.2 in that one. So in a large PDA, because there is a lot of filling into the left atrium, and the diastolic flow is higher, the passive flow is higher into the left ventricle. So we tend to see a very higher E wave compared to the A wave. So this is a baby with a PDA which shows a reversal of the EA ratio. So this is another. This is not widely used. We do not in our institution, we don't use these indices index very routinely. I'm not sure whether you use that, but this is another index which we can use, and it's relatively easy to measure. The interventricular relaxation time, IVRT, this is not a basic index. It is a little bit difficult to measure, especially with a fast heart rate. So, and it is a lot of inter-observer variation. So I just mentioning it. I'm not going to explain that in detail, but this measurement, we can use it in normal inflow Doppler, or we can also measure it as a tissue Doppler. Tissue Doppler, I find it more useful, the IVRT measurements. Okay. The last measurement, I talked about ductal size, ductal shunt, and the left heart volume overload, and the systemic and pulmonary overcirculation. The last measurement is systemic underperfusion. So when you have a large PDA, there is a lot of steal from the systemic circulation to the pulmonary circulation. As a result, there is a diastolic flow reversal in the descending thoracic aorta as well as in the abdominal organs. So with some experience, we can actually Doppler the descending thoracic aorta. Technically, this is a little bit difficult, but with practice, we can actually get a good view. But the only thing we need to remember is it is actually we need to Doppler, put the Doppler pulse wave volume, the Doppler sample, below the origin of the duct, beyond the origin of the duct. If you put it above the duct, you won't get an accurate flow. So the picture on the top of the picture, the cursor is below the duct. You can see the systolic flow because this is that aortic flow going away from the probe. The below the baseline is forward flow in the aorta, and then the above the baseline is a retrograde flow. So the picture below is normal diastolic flow, normal flow. The one above is a reversal of the diastolic flow. Any retrograde flow in the aorta indicates hemodynamic significant PDA. And again, this is an example, one of our patients where we Doppler. So the echo cardiographer actually put the Doppler sample above the duct. You can see the small duct in the red color. And then the sample was put above the duct. So you see a forward flow. This baby has got a quite large duct. But there is still a positive diastolic flow. But so this is wrong. So this is basically we are sampling the distal arch, above the aortic ductal origin. But if you go quite distally, then we can see in the same patient, we can see the diastolic flow reversal. This is a forward flow and then reversed flow in diastole. So where we place the pulse wave sample volume is very important. So it needs a little bit some expertise in getting this value, but this is a very useful measure. Basically, this is a very objective assessment. If there is a steal of retrograde flow in the aorta, it definitely indicates a hemodynamically significant PDA. And if the baby qualifies for treatment, I would treat that PDA. This is another patient. The same patient where we put the probe in the subcostal view and then looking at the aorta, and then we can see in the color Doppler, you can see the celiac axis and then the superior mesenteric artery just on the next to the celiac axis. You can see that. And superior mesenteric artery is sometimes difficult to Doppler because usually it will goes a little bit with an angle, but the celiac axis is easy to because your Doppler angle can be quite parallel to the blood flow. So if you get a good flow, then you see the flow. This is a forward flow, and then below the baseline is a reverse flow. So in this patient, the same patient I showed earlier with a large PDA shows a flow reversal in the celiac axis as well, and then descending thoracic aorta as well, and abdominal aorta as well. So it indicates that this is a hemodynamically significant PDA. So the same can be done, the same measurements can be done in the cranial ultrasound using the anterior cerebral artery or middle cerebral artery Doppler also. So you can measure the celiac trunk or superior mesenteric artery or a middle cerebral artery or anterior cerebral artery. So the flow look like this. On the top picture, it is a positive forward flow, absent end diastolic flow. And then the third is C is the reversal of the end diastolic flow. Likewise, in the middle cerebral artery, A is normal flow, B absent end diastolic flow, C reversed end diastolic flow. So the absent and reversed flow indicates that there is a hemodynamically significant PDA. Okay, so that's the common hemodynamic measurement and PDA indices. I come to the end of my talk. So in summary, what we can follow a scheme because there are so many measurements. If you are doing especially if you are a beginner, we are doing an echocardiography, how we do look at all the indexes. A practical tip is I personally, I always start with the apical 4-chamber view. Some of the neonatologists will prefer to start with the parasternal long axis view, but I start with the apical 4-chamber view. Then I look at the subjective assessment of the left heart volume overload, LA, LV dilatation. Then in the same view, we can do a mitral valve inflow pulse wave Doppler and then measure the EA ratio. In the same view, you can slightly tilt the probe and then get a apical 5-chamber view, measure the aortic Doppler, pulse wave Doppler in the ascending aorta or just beyond the aortic valve, measure the aortic VTI, measure the left ventricular diameter, and then you can measure left ventricular outflow measurement. Next, parasternal long axis view. In that, we can assess subjective assessment of left atrial dilatation, fractional shortening and LV-EDD on M mode, and the left atrium aortic ratio using the M mode. Next, go to the parasternal soft axis view and then the ductal cut. Check the PDA or not, and then if the PDA present, PDA diameter, left pulmonary artery diameter, the PDA shunt pattern, like I mentioned earlier, pulse wave as well as continuous wave if there is a high velocity, PDA shunt velocity, peak and systolic velocity and minimum diastolic velocity. Then measure the main pulmonary artery pulse wave Doppler and left pulmonary artery pulse wave Doppler. So all can be measured in the parasternal short axis and high parasternal short axis views. Then go to the aortic arch view, measure the descending thoracic aorta flow reversal. Then using the same probe, we can go to the subcostal view and look at the celiac axis and then look for the flow reversal in superior mesenteric artery or a celiac axis. Then if most of you do familiar with the cranial ultrasound as well, I usually change the probe to the cranial ultrasound probe and then look at the anterior cerebral artery and middle cerebral artery and then do a pulse wave Doppler there. That completes the most of the basic indices, and then we can, and based on these indices, we can measure the hemodynamic assessment of that PDA. Okay, I hope it is not too difficult to follow, and that's given an overview of the PDA and the different shunt patterns and then the common echocardiographic indices. If you need any further reading, this is a quite useful resources. You can take a screenshot and you can read a little more about that measurements. But the key is actually practice it in your units, because it's even though I talk that this actually takes years of experience to get a good views like that. For the beginners, there will be always a bit of a challenge with especially getting a good Doppler measurements. Most of the time, what will happen is we will get a good color flow. By the time we put the cursor, our hand might have moved a little bit, and then the image will go off the screen. So we need a little bit of steady hands and then a bit of practice. But with practice, it's doable, and it's a quite useful skill to have. And with the routine echocardiography, we can target the clinical management of PDA much better in the diagnosis as well as management, and then we can actually improve the patient outcomes. Thank you very much.
Thank you, Dr. Abdul. It was really great. I don't know about anybody else, but I enjoyed this a lot. And you covered all the basic parameters and everything.
Thank you.
And basic indices so nicely and clearly and crystal clear that I think so it will be very helpful for the people. We'll just follow that in the sequence we have for everyone.
Yes.
If they have any doubts, they should watch